Now, palliative care need, of course, we know that palliative care, the modern palliative care has started with cancer patient management. You know the Amy Cicely Saunders. She was involved with involving giving care in for the cancer patients. That's how the modern palliative care started. But the demographics of of palliative care extend far beyond cancer. 40 to 60% of all global deaths require palliative care. So if you get the whole number of patients who need palliative care, out of that, 38.5% of them actually patients with cardiovascular disease. So the highest percentage of patients who need palliative care actually not cancer, it is cardiovascular disease. I don't know how many of our cardiovascular end stage heart failure, end stage stroke, the stroke patients are getting proper palliative care in Sri Lanka, right? So 34% of those patients who need palliative care are cancer patients, most of them, but not limited to advanced and terminal stage cancer disease. So you need to understand not only advanced or terminal patients, cancer patients need palliative care, even at the beginning with any prognosis, cancer patients need palliative care. So 34% of patients who need palliative care, they are cancer patients. So 10.3% of patients who need palliative care are chronic respiratory disease, patients with chronic respiratory disease. So chronic obstructive pulmonary disease, emphysema, so various respiratory conditions. So 5.7% of them are HIV/AIDS patients. So 4.6% of them are end-stage complications, diabetes with end-stage complications. So care is also officially recognized for neurological diseases, dementia, Alzheimer's disease, for example, and organ failures like end-stage liver disease, end-stage renal failure. Uh, so those patients also need palliative care, and extreme frailty and old age. So there are certain conditions recognized as that they need palliative care. Also, there are some infections. In addition to HIV/AIDS, the multi-drug resistant tuberculosis, also those patients need palliative care. Now, care should scale alongside disease progression, not wait for curative failure. So, in the older model, which is a linear model, initial part you give curative care, and when patients start dying or when it is not curative stage, you are labeling the patient's treatment as palliative care. Then after death, actually at the initial stage, they didn't even consider bereavement care. So this model has rejected long ago. So the WHO integrated model actually considered palliative care should start at the time of diagnosis. So the intensity or the proportion of palliative care you need to provide at the time of diagnosis may be very minimal. The most of the time what you need to give is disease modifying or disease directed curative care. But with time, if patient's disease progress, the intensity of the palliative care increase with time. And at one point where you understand, you learn that disease-directed treatment is no longer going to help this patient, so the palliative care or the supportive care will be maximally needed for those patients. And after death, that period is the bereavement care part for the caregivers and the relatives. So you need to understand palliative care is for patients with life-threatening illnesses and their caregivers and the relatives. So all these three components, all these three groups has to be delivered, has to be received palliative care. They need palliative care. So carers should not be forgotten because it's an important group that need palliative care. So this is the WHO model. So in that model, you need to start palliative care at the time of diagnosis, maybe in a small intensity. Now, there are three distinct trajectories of human declines. Easiest one to understand is cancer trajectory. So initial part, when with the disease directed treatment, sometimes patient go through a stage. I mean, the patient's functions will be fluctuating in between a certain level. Even though this represent as a straight line, it may be fluctuating like this due to the treatment effect, side effects, and things. But overall, it is a steady line. But if patient get a progressive disease and if patient started to decline very rapidly, then if the decline is daily basis happening, then we know that this patient has entered into the terminal stage. So if patient deteriorating daily basis, so we know that patient is having a number of days remaining. So that period is like this, rapidly deteriorating. In between this period, if patient is deteriorating monthly basis or weekly basis, but not reversible, functions are not reversible, that period is called, when they have several months to live, that period is called end of life period. So this is, I mean, cancer patients' deterioration is very comparatively to other trajectories easy to understand. So when the trajectory is like this, if you know your patient is in this place, so you need to know what to do, what you should do mostly. So how to introduce, how to provide palliative care in end of life situation, how to provide palliative care as a terminal care in this period there where the terminal phase is there. Now, organ system failure like heart failure, liver failure, renal failure, or respiratory failure, patients' functions deteriorate with time. On and off, there will be exacerbations, mostly due to infections. So, patient will deteriorate. So, the clinical staff will give the maximum support to the patient with disease-directed treatments. So they try recover this episode. But you need to see, even though the recovery is there, they don't go to the same functional level where they have started. You can see here, there's a gap. So the functional level is little less than where they have started the crisis. Then again, with time, another crisis. So they deteriorate rapidly, but the healthcare team interventions will be done, and interventions will be done, and patient will recover again, not to the same level where the crisis start. So overall, the functions are deteriorating. So the number of crises now, for example, initially patient will admit maybe once in 2 months, then it changed to once a month, then it changed to once in 2 weeks, like. So you see there's a pattern. Crises occur more frequently. So if the patient admit twice a week, like, then you know now the recovery is not possible. So at this stage, I mean, even before, you need to discuss about the advanced care plan, where how you should manage this patient. But at this stage, whether you give disease-directed treatment or not, you need to discuss with the patient and the family. Better if you have discussed this with them well before, and you have a good plan. But this is a difficult area where you don't know whether this patient will recover or not. So sometimes you might have to give a little bit of trials and see whether the patient is recovering or not. If the patient is not recovering, you know that patient has come to a stage where irreversibly patient is dying. So that time you need to provide the terminal care for this patient. You can see it's not like this, like a cancer patient's disease trajectory. So the organ system failure patient's trajectory is bit difficult to understand. So the clinician has to face some difficulties of identifying the terminal phase. But with experienced palliative care clinician can identify this phase going through the history, and they can help the family members and the patient. So the third one, the dementia and the priority trajectory, it's very, very difficult. It's like this. No one knows at what time patient is going to die. So sometimes you might see almost patient is dying, but patient might recover. But overall, the trajectory line is going down. So at one point, patient might die. So it's very difficult to identify the terminal phase. So the continuous deterioration is there. So because decline is rarely predictable, triggering palliative support based solely on a 6-month prognosis leaves millions suffering needlessly. Now, sometimes, I mean, a lot of people think that when the patient's having a 6 months prognosis, you should introduce the palliative care. You should introduce palliative care. So that is wrong. So you can imagine this sort of trajectory. It is very difficult to identify this 6 months prognosis. Here it is very, very difficult. So palliative care should start well before. So patient symptom control should start well before. So therefore, you don't wait till the 6 months prognosis where you can miss the patient. So patient might die with a lot of suffering if you wait for the 6 months prognosis where you will not be able to diagnose the 6 months prognosis accurately, right? And another very important thing is, as a clinician, you should never tell the patient that this patient is having 6 months, or this patient is having 4 weeks, this patient is having 2 weeks to live. If you give a number, you are going to be, I mean, you will be wrong all the time. You are wrong, almost you are wrong. So if you give a prognosis like, say, this patient is going to live 9 months, after 9 months, if patient lives, the family members get angry with you. If this patient died at 6 months, again they will angry with you because they think that you have mismanaged the patient when you gave a 9 months survival prognosis, right? Therefore, for a patient like this, never tell the number of months or weeks or days that they are going to live. What you can tell is, if patient is deteriorating monthly basis, you can tell patient can live number of months. You can't tell exactly how many months. But suddenly, if that patient start to deteriorate weekly, then from that point onwards, the life expectancy would be number of weeks. And if that change again to daily basis deterioration, then from that time it will be number of days. So that is the way you should tell how many are the time period that the patient is predicted to be live. Because family members also need to know roughly what is the time duration they are having, because they need to plan. But not you should not tell the exact number. The early integration paradox: less aggressive end of life care yield longer survival. Now this is the trial, clinical trial I have mentioned you. They have selected metastatic non-small cell lung cancer patients. At the time of diagnosis, they are metastatic. So they divided randomly into two groups. One group had only the disease-directed treatment. This was done in 2010, right? And the other group, other arm, in addition to the disease-directed treatment, they have started early palliative care. Now, the clinical arm, the study arm with only the disease-directed treatment had more aggressive end-of-life interventions. Right? They had more aggressive interventions. 54% of them had aggressive interventions, uh, and they had encountered higher depressive symptoms. 38% of them had depressive symptoms. and their median survival was 8.9 months. The disease-directed treatment or the standard treatment plus early palliative care arm, they had less aggressive end-of-life interventions compared to more disease-directed arm, 54% versus 33%. And they had fewer depression symptoms. That means they had less suffering compared to 38% with only disease-directed treatment arm. This is 16%, and significantly higher quality of life. Factel score 98% versus 91.5%. So they had very high quality of life compared to the other arm. So their median survival was 18.6%, 6 months, and this was statistically highly significant. So this study proved that incorporating palliative care early in the disease trajectory cause a lot of benefits to the patient, good quality of life, and even longer survival. So early integration mitigates the physical and psychological toll of the disease and its treatment. So it is very important to understand that this is clinically proven, study proven.